Hi, everyone. This is a lecture on gastrointestinal pathologies and disorders or alterations. So this image I like a lot, and it's because I had a dog that looked a lot like this. And basically this to me is showing that one of your basic concepts from anatomy and physiology should have been that the mouth to the anus is one continuous um, canal, and it's called the alimentary canal. And so it's one pathway, and hopefully you learn that in A and P. So just something fun to get you interested, hopefully. So there's several pathologies that I'd like to discuss: anorexia, constipation, diarrhea, dysphagia, jaundice, nausea, and vomiting. Those are a lot of symptoms that you'll see with gastrointestinal disorders, and it gets confusing because about every one of the disorders has vomiting and diarrhea as a possible symptom. And so it can get confusing, but anyway, let's take a look at those, and then we'll go into a little bit more details about the different disorders. So in anorexia, sometimes we tend to think of eating disorders, and that's anorexia nervosa. That's is a mental health issue. That's an eating disorder, body image, all of that, dysphoria. But anyway, there's other ways to be anorexic, and that could be caused by, it's basically when you have a lack of appetite, and it's can be the result of medication or chemotherapies and things like that. But it certainly can be a form of mental illness. But you can be have chronic illnesses that cause you to have the need for nutrition, but not the appetite for it. And the symptoms obviously would be weight loss, fatigue, nutritional deficiencies, and dehydration are a few. But keep in mind that it can have um, adverse effect and impact on healthy systems like your cardiovascular can be impacted, and heart attacks are possible too with anorexia nervosa for sure. But anyway, just a general term, anorexia, you have the desire and the need, I'm sorry, the need for nutrition, but not the desire to eat, no lack of appetite. Constipation we've all experienced. It's that infrequent, difficult, or painful bowel movements. And it basically, there's just slow movement of the stool through the colon, and it can be a result of dehydration. Your colon needs the right amount of water and fiber to handle the roughage that it needs to handle to get out. So some of the causes of constipation can be painkillers, but also low fiber diets and inadequate fluid intake. Your digestive system likes it when you move around, so lack of physical activity can contribute to constipation and some neurological disorders. And like I said, iron supplements and other medications as well. Symptoms are hard and dry stool and straining during bowel movements. Nothing new here. Some bloating and discomfort as well. So diarrhea is a little bit of the opposite of that, where there's the frequency of bowel movements is increased, and there's loose and watery stool, and that can be due to malabsorption issues with your small intestine, or infections or inflammatory conditions. Um, and the results could be bacterial, like an infection of an organism like a virus or a parasite or bacteria. Some people have food intolerances like lactose intolerance. Celiac disease is something we'll talk about later, but that's more of a malabsorption issue. But anyway, inflammatory bowel disease, Crohn's, ulcerative colitis, those are some things that can lead to diarrhea. Diverticulitis, a lot of things do in this unit, but, or, obviously the side effects of medication like antibiotics. We've been all taught that in our history of having infection and taking antibiotics. But obviously, the symptoms are these loose, watery stools and cramping and dehydration, and it could actually make you feel sick to your stomach and vomit. Dysphagia is a different one that I'm hoping is not a new term, but it's when you have difficulty swallowing, and that could be on any side of your throat, basically, in your esophagus or your pharynx or your larynx. And so there's all ways that this could be impacted, but also neurological disorders um, like Parkinson's and ALS. That just that movement is tricky in that. You could have some esophageal issues with Barrett's, and that's something I'll talk about in a little bit here. But GERD is the reflux disorder where you have acid coming back up. Or you could have obviously tumors or obstruction in the esophagus and muscular disorders. That's peristalsis and movement. You got to have that. You will experience difficulty swallowing, choking, or coughing when eating, regurgitation of food, and you just don't eat. So there's some weight loss. All right, jaundice is a condition that I'm sure you're familiar with. Sometimes babies get it naturally because their liver just isn't developed or ready to handle everything yet. But it's this yellow discoloration in the sclera of the eyes, and that's due to a high bilirubin content in the blood, usually related to liver disorders or disease. But it can be before the liver, there's just could be increased bilirubin production or liver disease, or after the liver where you have an obstruction in the biliary um, uh, I want to say vessel, but the connection to the gallbladder. So there's a lot of ways you can get jaundice, but you can also have excessive red blood cell breakdown, hemolysis, gallstones, and blocking that flow, and like I said, newborns. And you'll see yellowing of skin and eyes, dark urine also, and clay-colored stool, and some abdominal pain and fatigue. Nausea is that something that we've probably all experienced. It's discomfort in the stomach and that urge to vomit. That vomit center is part of the brain. It's kind of something we can't control real well. It's not easy to stop it. You might be able to start it, but it's not easy to stop. But some common causes are motion sickness and any food poisoning or infections of the belly, gastritis, pregnancies where we have morning sickness, obviously chemotherapies and opioids, some medications. But it's that discomfort in the stomach, and you get some increased salivation, sweating, and dizziness that sort of um, prevails before you actually vomit. And that whole process of vomiting is that when you forcefully expel the contents of your stomach through your mouth, and again, that it's not something that's easily stopped, as you know. I always feel better after I do it, so I'm kind of all for it, but some people hate it. I don't like it, but I'd rather get that done and get some of that stuff out of me and move on. We've already kind of talked about the causes, but some brain tumors and intracranial pressure can cause the vomiting as well, concussions and such. Nausea before vomiting usually happens, and there's abdominal contractions, and disorders of acid and bases are also those imbalances can lead to vomiting as well, and they can be caused by it as well. So keep that in mind. Right, we have a lot of a lot of disorders, and we'll group them a little bit and we'll talk about each one. And we have about a slide per disorder. And I've got them organized in the sense of there's some that I would call obstruction or motility disorders. Then I look at liver. I like that. Liver gallbladder disorders, inflammatory bowel disorders, and malabsorption, gastroesophageal and stomach, colorectal and liver. So I kind of have liver there twice, so pardon me on that one, but we'll get through it. But what is missing? I forgot to say that. The pancreas is missing from the slide, but we will add a little bit to our slide about the pancreas. The reason it's missing is your book tends to talk about it more as a endocrine organ, but it does have digestive purpose. It supplies digestive enzymes to help the liver and the small intestine work, so keep that in mind. All right, so obstructions, let's look at the first one, which is hernia, and that's a protrusion of an organ, and it's commonly intestines, and it just sticks out, it bulges. You can see down here, there's a bulging through the abdominal um, wall where it protrudes out. There's different kinds. There's hiatal, which is when you have your stomach goes up through your diaphragm and then lies somewhere in your esophagus instead. So that increases the acid up there. I'll talk about that in a minute. You have inguinal and umbilical and incisional. Yes, you can get a hernia as a result of surgery. My grandpa had a navel one and umbilical, and it looked like that. It just always creeped me out. My brothers have had the inguinal ones that are typical with males and lifting. But as you'll see, obesity is a common symptom in a lot of these disorders. I have a hiatal and it doesn't maybe look like that, but I'm overweight and my doctor wants me to lose weight to help that hiatal hernia. It just increases the abdominal pressures and but that could also happen in heavy lifting and just some weakness, congenital weakness. It could just be some genetics. It seems like a lot of my males in my family get hernias. Um, there's some risk factors, like I said, obesities and common, a lot of coughing and heavy lifting, and the symptom would be the bulge, discomfort, and it's possibly an obstruction. All right, another type of motility or gastrointestinal obstruction disorder is the intestinal obstruction. You could have some sort of blockage in one of the intestines, and that could be due to tumors or scar tissue adhesions, is like what we like to call them. But it also could be functional, where it's not moving, the muscles aren't moving things through. And also, another cause is kind of where you have a twisted colon, hernias, inflammation, tumor adhesions. Surgeries put that at risk because when you heal, there's a lot of possibility for adhesions that form. Crohn's disease is involved. Again, signs are going to be bloating, vomiting, constipation, abdominal pain. It makes sense. You can't move things through. There's a block. There's going to be pain and constipation. Tumors are a big one, folks. But anyway, I threw this slide in because we're looking at intestines, and these are perforations or abscesses. I just like the pictures. I didn't really talk about these as far as disorders, but these are infections that can occur. A likely cause of this could be diverticulitis, where you have, or other bowel disease, but you really don't want your bowel to perforate. That can lead to sepsis and infection in the whole system. All right, IBS, irritable bowel syndrome. It's basically it affects motility, and your bowels are sensitive for whatever reason. The causes are not really well known, but stress seems to be associated, female gender, other infections or changes in your gut microbiome. But you would see abdominal pain, bloating, diarrhea, constipation. My grandma says she had this, but sometimes I wonder if she didn't have diverticulitis because that seems to run in her family. There's similar symptoms, but it's hard to know definitively how to diagnose this, but they kind of rule things out. All right, this is a look at IBS, and you can see inflammation. So that's if they do an endoscopic ultrasound, you could, or a colonoscopy, you can see some inflammation. You could see ulceration and fistulas in lining of intestines. Those are sort of different things, but I just wanted to kind of give you some images of what things look like. All right, let's look at some liver and gallbladder disorders or liver failure. It's basically when, usually we associate this with alcoholism, but it can be other causes. Toxins, hepatitis can cause the liver to fail. There's just chronic damage, and sometimes the result you can see on here is a really swollen belly. That's a belly full of fluid called ascites. Yeah, you can also associate jaundice with this. And one of the other liver failure also is associated with itching. A symptom is itching, and it's probably related to here. There's some emulsifying salts and bile salts, and it seems to be related to that. But do remember to associate that. But jaundice, ascites, itching are signs and symptoms of liver disorder. And yeah, but basically your liver is unable to filter toxins, so there's some other symptoms would be some confusion and yeah, some clotting issues. Our gallbladder disease, your gallbladder is just this little organ that sits here and it stores bile, and it can improperly form what are called bile, some stones. It helps emulsify some fat. Um, anyway, it sits here and it's part of the biliary tree, and it does take if it forms stones, some things get blocked, and you could see jaundice again, and you'd have upper right quadrant pain and nausea and vomiting. So the causes could be excess cholesterol, or your bile's not moving, or infection. It's not always known, but when people get gallstones, there's a lot of times with those stones are you wait, you try to break them up, or you take out. Usually the gallbladder is taken out. So if a person, a lot of time females, I would say, present with gallbladder disorder. But somebody is losing weight and they're not trying and they don't feel well and they don't feel like eating, obviously the first place we look is gallbladder, but the second thing you should look at is pancreatic cancer. Those are two big symptoms like unexplained weight loss. And so keep that in mind. And if you remove the gallbladder because of its emulsifying of fats and it's helping in that, fatty foods do not go well with your diet. So keep that in mind. All right, let's look at something called portal hypertension. It's basically increased blood pressure in this area where the portal vein is supplying the liver, and it's usually related to cirrhosis, where you'd have this increased blood pressure, and also find right-sided heart failure, increased thrombosis could cause this as well. But anyway, you would see some of these things similar to liver disorder or failure where we see ascites, but you'd possibly see what's called esophageal varices that I'll explain here in a minute, and splenomegaly, which is an enlarged spleen, basically. So esophageal varices are enlarged and dilated veins in the lower esophagus. Um, these usually are the result of alcoholism and cirrhosis or portal hypertension and obesity, but it's usually chronic damage that causes these to form, and they're very dangerous if they rupture. And that's one of the biggest, it is also strongly associated with portal hypertension. And so, anyway, there's resistance to blood flow, it's weak vessels, all of that, and it can lead to losing a large volume of blood. So, if you see somebody throwing up blood, this is something to consider. Here's some images of that. This is sort of a diagram, but this is a little bit more real of what they look like. All right, looking at some inflammatory bowel diseases and malabsorption. The one that comes in mind is Crohn's. Um, the thing to differentiate Crohn's from ulcerative colitis are both inflammatory disorders of the colon. In Crohn's disease, you could get inflammation in the whole GI tract, okay, including deep ulcerations in these fatty deposits around some of the colon. But anyway, associated it with the whole GI tract, whereas ulcerative colitis is just with the large colon. Both are related to autoimmune systems and genetic predispositions, family histories, diets, and you'll see malabsorption. Nutrients are not getting broken down as they should. So anyway, the malabsorption is really part of mainly the small intestine, so think of that, but you'd see weight loss and fatigue as well. Usually these are able to be picked up based on, looking at the tract, the alimentary tract, and also um, inflammation markers. Ulcerative colitis is just with the colon, the large colon, and it's again, it could have environmental triggers, but typically we think about it as an autoimmune disorder, diet, stress, family history, but symptoms would be bloody diarrhea and abdominal pain, weight loss. Those are very similar symptoms. Um, it's a problem, and I told the story. Pause. Hang on. Sorry about that. So let's take another look at ulcerative colitis in the sense that I was going to tell a couple stories. I made mention in class that someone I knew had their whole entire colon removed because of this. It was so damaged it was more damaging than benefit to be in. And so they took it all out and they created kind of what's called a J pouch from her small intestine, which I thought is very, very cool. I also knew somebody that had this very badly or very bad, and it led to liver failure, and he needed a liver transplant. And he did get that from his daughter. They took half part of her, a lobe of her liver and put it with him, but he knows that it's only going to last about 10 years, and he's approaching that. So it can be very devastating, I guess is what I'm trying to say here. All right, diverticulitis. This is a unique situation. You have what are called diverticula that form, they're little pouches that form on the colon, and those pouches collect problems like certain foods get trapped there, and your body doesn't deal with it from a pathogenic removal situation. You get an infection, basically. It's like having an abscess on your colon. And they say it's a result. There's confusing information on how to treat this, but when it flares up and becomes infected, we call it diverticulitis. A person like me could have diverticula, the potential, those little sacs, but until a food gets trapped or something happens where they get infected, I'm asymptomatic. And there's a couple different types. I think there's one, types that are more complicated than others, and mine's less complicated, diverticulitis. I don't have an abscess where I'd have to get a drain to drain that. My brother has had that. Mine seem to resolve themselves, but I can tell when I get really tired, I get a fever and I just sleep. But anyway, if I can manage it pretty well with more fiber in my diet. So low fiber is a risk in obesity. So, but symptoms would be lower left quadrant pain. I get a lot of just cramping, and usually results in more diarrhea for me than other, but you'll have changes in bowel habits. Here's some sections of the colon that show these diverticula. You can take a look at those. All right, so some other malabsorption diseases. This is celiac, and you'll see the atrophy of the microvilli. They're smaller, and so the absorption of nutrients in food is not successful as well as it should be, and it's just that inability to actually absorb the nutrient you take in. There can also be, other than celiac disease, there can be pancreatic disorders where these enzymes are not coming to you and not helping. Risk factors are typically genetic and autoimmune and similar symptoms that we've seen, but you'll see more vitamin deficiencies with this disorder. Oh, our good buddy GERD, gastroesophageal reflux disorder. Think and relate this to a dysfunction of the lower esophageal sphincter. The sphincter is a muscle that's supposed to control. It's kind of like a valve that controls what goes down and what doesn't come up. But a hiatal hernia, like I said earlier, can intrude the pass through of the diaphragm and come back into the esophagus, and that creates a very acidic condition and can result in what's called Barrett's esophagus. And you actually see your body will adapt to that situation where there's acid, but your stomach likes acid. It has the ability, its cells can handle that low pH, but the esophagus doesn't. So what it does, it tries to recover from that acidic condition by changing the composition of the cells. It's called metaplasia. And anyway, that weak sphincter muscle can be a cause in obesity, diet, smoking, but you'll get that acid buildup in your esophagus. A chronic cough would be a symptom, heartburn. Now, I have it pretty bad. I have to take medication, but I have never had a symptom. They just found it when they were looking for other problems related to uh, screening my pancreas for cancer. So anyway, that's a pleasant discovery. Um, is there anything else? Nope, that's all I wanted to say there. So let's look at peptic ulcers. This is some erosion of the stomach lining. They found that during some of my ultrasound, endoscopic procedures and endoscopic ultrasounds that are looking at my pancreas, but they're in the meantime seeing areas of inflammation. I was never bleeding with an ulcer, but um, they did biopsy my ulcer to see if it was caused by a bacteria called H. pylori, but it was not. Actually, that's an interesting story. H. pylori was actually discovered by a researcher who infected himself. But anyway, also NSAID use. I can't take ibuprofen, and it's my drug of choice, but that's something that could contribute to ulcers. And let's see, other risk factors, smoking, alcohol, and stress, and similar symptoms that we've seen before. But the treatment is to reduce the stomach acid. So I take a proton pump inhibitor to alter the hydrogen ion concentration to be more suitable for my belly. Anyway, appendicitis, we've all heard of this. It's lower left, I'm sorry, um, right lower quadrant pain. You can see where it sets on the right side of that colon. And it's an infection with the quadrant pain that's pretty indicative of an appendicitis attack. And the goal is usually there's some sort of obstruction, but the goal is to get rid of it. It's really a vestigial appendix. It's not appendages, I should say. It's something that we don't really need, so we can take it out. It's better to do that before it ruptures. If it gets so inflamed and it ruptures, it can cause systemic infection. And you'll diagnose it with mostly the quadrant pain and the fever, and then rebound tenderness. All right, polyps. Polyps are just abnormal growth in the intestinal lining, and typically we think of them in the colorectal area, and that they could be in the stomach as well. I realized I had one of those too. Boy, when they go down and look, they kind of find all sorts of things. But polyps are usually benign. They're just abnormal growth, and if they look on a diagnostic imaging when you're down there looking around with a colonoscopy, they'll take them out, and if they look pink, they're usually pretty safe. And so they can be precursors to colorectal cancer. They're caused by different genetic mutations or chronic inflammation or diet. And often you won't know you have them. They're asymptomatic, but you can see some bleeds, or rectal bleeds, or changing in bowel habits. But the good news is, folks, if you have any sort of symptom in the colorectal area, you should get it checked because colorectal cancer is on the rise. I'm very serious about this in younger people, 30-year-olds, and I don't know why. But you can remove polyps and kind of preemptively discourage cancer. It's really good to get screenings. You start them at 50 and then you get one every 10 years unless you have a polyp, then they do it sooner, but they'll just take them right out. And usually that takes care of your worry about colorectal cancer. Colonoscopy is a way to look at all of this. They lay you down on your left side and they do what they do. You can see pictures there. I'm kind of a nerd, so I like to look at these things, but I get them done and I don't want to look at my own. All right, hemorrhoids are interesting. They can be in the anus or on the outside of the anus, and they're basically swollen blood vessels in the rectal anal area. They can, like I said, internal or external. There's you could create them from delivering babies or straining during bowel movements or just dumb luck, but obesity, there it is again. But you'll see some itching, pain, discomfort, and bleeding. So if you have rectal bleeding, you're looking at something is not right. And so it's likely a hemorrhoid, but you should get it checked out. Hepatitis is an infection of the liver. It's caused it's where basically inflammation of the liver. Let's correct that. But it can be caused by viral infections or alcohol or toxins. Hepatitis is typically what we think of as an infection, in my opinion. And there's different ways of there are different strains, A, B, or C, based on the organism involved. But there's some risk factors related to unprotected sex and blood exchange, IV drug use, and of course alcohol consumption. And one of the symptoms is similar to any liver disease where you have just jaundice and fatigue, nausea, and dark urine and abdominal pain. We've already talked about jaundice. So let's hit the pancreas and be done with our digestive one. So again, it's a very, very unique, and I'm really concerned about my own because this is where I could have problems with my tumor suppressor gene that doesn't stop unwanted growth. And you can't really live without a pancreas. You only got one. I wish God would have thought about redundancy in all organs, but that's just not possible. We have one heart and one pancreas, but we can get a heart transplant, and you can get a pancreas transplant, but it's not always as easy. But anyway, it mainly controls your blood glucose levels by secreting different hormones and responding to in homeostasis ways to make it just steady. And we'll talk about some endocrine systems later, but it does secrete digestive enzymes, and it can get inflamed with what we call pancreatitis, or it can be from gallstones, which is the most common cause, or alcohol abuse, trauma, infection, certain medications, and genetic factors. And that's a pretty stressed out little pancreas down there. But there are some transplants, and used to be, if you, like, I have an aunt that has her pancreas, it was taken out. It wasn't transplanted a new one, but they removed it. Typically, when you have pancreatic cancer, it's found too late, and they don't often do much except the standard surgeries and chemotherapies if possible, but it's not a good diagnosis. But she had pancreatic cancer and they took it out, and she lived for a long time. She was just very frail and weak because she couldn't eat real well. But they used to not be able to do that because they didn't have the ability to supplement those digestive enzymes that are needed during digestion. You can monitor your blood glucose with hormones. So there's a lot of management that you have to do if you lose your pancreas with digestive enzymes and blood glucose. All right, that's all we have on that one. Thank you very much.